Okay, welcome to the third panel discussion of Malaria Consortium's 10th anniversary event. On this session, we will be discussing the key developments and the key lessons learned, as well as key challenges in the move towards reaching malaria elimination. We will be discussing topics and aspects around drug and artemisinin and insecticide resistance. We will talk about mobile health technology to support malaria elimination programs. And also, we will discuss briefly the move from general fever surveillance into more malaria-specific surveillance. My name is Arantxa Roca. I am the Asia Technical Director for Malaria Consortium. I am an epidemiologist by training from the London School, and I worked for 5 years in Malawi before moving to Cambodia 2 years ago. I'm currently now supporting the technical coordination of Malaria Consortium programs in Asia. And I would like to start introducing the keynote speaker and the panel members for this panel session. First of all, I'm sure you all know we have known Dr. Sylvia Meek, who is one of the founders of Malaria Consortium, but also the technical director of Malaria Consortium. Sylvia, she was the director for the Department of International Development's Resource Center for Malaria Control, and which was a partnership between DFID, the London School of Hygiene and Tropical Medicine, and the Liverpool School of Tropical Medicine. Her work includes technical advice, especially on program design, management and evaluation, and technical leadership and strategy development. She's also part of the Rollback Malaria Working Group on case management, and overall she has more than 25 years experience of malaria control and has worked in several countries, particularly in Solomon Islands, Namibia, and Cambodia, although she is a malaria expert in pretty much all the countries now. Dr. Sylvia Meek has an MA in zoology and master's in animal parasitology and a PhD in mosquito genetics and control. We have 3 panel members which are malaria experts in this particular topic, and I would like to start by introducing Professor Simon Brooker, who is the Professor of Epidemiology and Wellcome Trust Senior Research Fellow at the London School of Hygiene and Tropical Medicine. He has over 15 years of collaborative research and public health experience, the majority of which is focused on neglected tropical diseases, malaria, and disease control in mainly African settings. Professor Brooker is currently supported by the Wellcome Trust to conduct research on the spatial epidemiology of NTDs and to develop new monitoring and surveillance strategies. He is also the principal investigator of a Bill and Melinda Gates Foundation project to develop a suite of mapping and modeling tools and resources for NTDs. He has a DPhil in infectious disease epidemiology from the University of Oxford and an MSc in health economics from University of London. Here with us today, we have the pleasure to have as a panel member Dr. Dysoley, who is a vice director of the National Malaria Control Program in Cambodia. His professional work experience is largely in the field of malaria and vector-borne diseases, and he has a focus on research, program development, and program management for malaria, dengue, helminth, and lymphatic filariasis, and other diseases. He has also been designated as the Emergency Response to Artemisinin Resistance, the ERA coordinator, which is one of the latest regional initiatives to contain or eliminate artemisinin resistance in the Greater Mekong sub-region. Dr. Slay is also involved in the development of the National Malaria Treatment Policy and the updating of the National Treatment Guidelines for the diagnosis and treatment of malaria. He has also been associated with the dengue program and NTDs program with CNM, the national program in Cambodia. And last but not least, we have Professor Chris Drakeley, who is working at the London School of Hygiene and Tropical Medicine. He has more than 20 years experience of working on malaria, with most of his time working overseas, mainly in African countries, including Tanzania and the Gambia. His research centers on developing a better understanding of malaria transmission, This includes studies aimed at understanding the fundamentals of malaria transmission dynamics in endemic populations and defining the infectious reservoir of malaria. His group is involved in the comparison and optimization of approaches of malaria transmission with a focus on serological markers for exposure to infection. These components are linked together by the evaluation of strategies designed to reduce and block transmission, including transmission blocking vaccines and drugs. So, as you can see, we have a very good panel to discuss a very important topic, which is really how we move towards malaria elimination in malaria endemic countries, and perhaps particularly in the Greater Mekong sub-region. So before any further preamble, I would like to invite Sylvia to present her talk on moving towards malaria elimination. Thanks.
Thanks very much, Arantxa. So I think this session obviously takes us in a slightly different direction from the other sessions, and I hope you'll find it interesting to look at and see the challenges ahead in malaria elimination, and I'm looking forward very much to hearing what the other panelists have to say. So I'm going to speak very quickly so we can get on to their bit. Okay, so I'm not going to talk too much about the details of elimination strategies. There have been quite a lot of discussions of that in recent years, but just to say that a lot has happened in the 10 years since the Malaria Consortium started as an NGO in terms of the big shift in ambitions in the fight against malaria. When we started in 2004, the focus was much more on scaling up. We'd already started to see the increased investments, the increased interest, and the greater seriousness with which malaria was being considered. But the aspirations were really just doing more of what we were trying to do on a very, very small scale before that. And so it was scaling up, achieving coverage, mobilizing resources, which obviously has been extremely successful owing to the coming together, I think, of partners around rollback malaria. If you look at the actual plan that rollback malaria developed to cover the time period of 2005 to 2015, there was very limited reference at all to elimination in that plan. But by 2007, things were starting to change a bit. I think people were getting more ambitious as the resources started to make people realize that actually a lot could be done. WHO released its new manual on malaria elimination, reminding us of what the strategies and the practical approaches were. And then obviously in 2007, that was also the year that Bill and Melinda Gates called for malaria eradication, which took people slightly by surprise, but it took people onto a new level of thinking beyond just eliminating country by country to go back to the thoughts on global eradication, which had been tried in the 1950s and 60s. So there was a big shift in focus of people's interest in malaria. But at the same time, it was around 2007 that people started to see the first reports of artemisinin resistance in Southeast Asia, and fears of pyrethroid resistance in Africa, particularly starting in the West, were starting to arise at that stage. And that, in some ways, made the need for elimination in certain areas more urgent. Just as in the previous eradication days, people had relied on what seemed to be infallible tools and hoped to be able to use those tools to 100% of coverage. We were coming back to the same situation where, again, we were relying on a rather small number of tools, and we were starting to get signs that we may lose them. So at the same time as increasing optimism, there was also a bit of a reality check as a result of this. And by now, what we're seeing is that many countries in the world, and particularly in the Latin America region and in Asia, have started to very much put together plans that bring in a focus on pre-elimination and malaria elimination. The APMEN network in Asia has brought together a lot of countries to decide on their strategies and develop their strategies on that. But even countries that have very high burden are starting to consider at least where elimination fits in their thinking. I think a lot of them are too realistic to believe that it's going to happen overnight, but they are starting to think, well, what do we have to put in place now in order for it to happen in the long term? But, so when the Rollback Malaria Global Plan, Malaria Action Plan was produced in 2008, they were starting to look in the long term at elimination. They didn't have a timeline for global progress, but they did actually anticipate at that stage that by 2015, maybe 8 to 10 more countries would have eliminated malaria. But they had three parts to the strategy, continuing and scaling up the control that is there, but really having a more directional approach than perhaps was seen before, and also underpinning the whole of it with extensive research. And I think this approach was necessary in many ways, not only because potentially it is feasible in a number of countries with the increased investment and the capacity to use the tools, but it was also necessary because the chances of actually maintaining the commitment to malaria, particularly political but also financial, would be very small if it was continuing always to stay at the same level. People needed a longer-term target to aspire to. So in terms of the way we engage in malaria elimination, obviously it was not part of our initial thinking really at the beginning of the organization, but we got involved quite rapidly and largely because of the work we'd been undertaking in Asia, where we were very, very concerned about the problems of artemisinin resistance, and the strategies that were developed around that are very much strategies for malaria elimination in the areas where artemisinin resistance has been found. And so that was the way we particularly got engaged in thinking, what does it take to eliminate? And one of the areas that's been a particular interest and focus of ours, because it's so essential for thinking about elimination, is really working on better surveillance systems and looking at the capacity to have much more detailed information than people had in the past, and actually linking that information with active responses. And that's been a real challenge. It's enough of a challenge to actually get the information systems working, but actually getting responses that are practical and actually have an impact has been quite difficult. Just to note that John Cox, who's in the audience from the London School, has been working very closely with our team in Cambodia on a lot of this surveillance work. Then advocacy in this area has been quite a priority for us. I think just this is particularly looking at strategies for advocacy at country level. There's a real concern as countries find that malaria is much less of a burden than it used to be, and they have obviously competition for resources, that they won't be able to maintain the level of intensity of action that's needed for elimination, because it's really you're just winding down at the time when you really need to be winding up, and it is very difficult for countries who have a lot of pressure to focus on the areas of greatest burden to actually allocate resources to the diseases of low endemicity. And we're quite interested, because we work in Africa and in Asia, to find out how we can apply lessons from Asia to the work we do in Africa. So because strategies for elimination are really not finally worked out, we do quite a lot of research in our Asia work, and the type of research that we tend to focus on is not so much the high-end drug discovery or tool discovery work. It's much more about how to improve the delivery of tools and interventions. it becomes quite a debate at times as to if things are not working. Is it because the strategy is not right, or is it just because you're not actually implementing the strategy that you say you're going to implement? And this comes up a lot in the efforts to eliminate artemisinin resistance. When we see that the actual proportion of resistant parasites is increasing, there's a real tendency for people to say, well, that's because the strategies that you're using are not appropriate. But when you actually look at how much of those strategies are actually being implemented, it's often far short of what it would take for that particular strategy to work. So we really need to have a much better understanding of these issues and actually testing out the systems and the strategies. And also really just working very closely with the programs and the implementers right from the start so that they feel part of it and can advise on how it should be undertaken. So one of the areas that we've focused on quite a lot in, well, partly you were hearing earlier in the community work that we do, but for Asia and the elimination work has been looking at how MHealth can be used in improving surveillance. And practical lessons are coming out of this. They're quite simple recommendations, but sometimes people forget the simpler parts and develop things that are perhaps over complex. So one of the things is that just when is technology really going to make things work? And how do you use the technology to improve a system that is sound? Sometimes it's applied to systems that wouldn't work anyway. So if you can't make it work manually, it's probably not going to work totally with just technology fixes. Issues like practical ideas in terms of using existing data, trying not to overload health workers with data collection unless you absolutely have to. So keeping the systems small enough for people to be able to comprehend and manage them. And then also decentralizing the systems as far as possible, because a lot of decisions are now being made at a much more peripheral level than in the past. And it's really important that those people have the information at their fingertips to make the decisions, both on timing and on strategies. And this does take quite a lot of effort in terms of making sure that there's enough training going on to keep people fully up to speed with what they're doing. And one of the tools that's been developed in Cambodia, and Dr. Dysoley knows this one well, and I think it's quite widely used in the program there, is the Cambodia Malaria Bulletin, which was set up by, by having a proper database of all the villages and health facilities in the country, getting data reported on a monthly basis, and into an automated system which then produces very user-friendly outputs. And I think the focus here has been on getting data available in a way that it can be used effectively, because it's produced in a way that answers the questions that the implementers need. So although you won't be able to see at all many of the details on this, what it has is systems where if things are going wrong, it'll go red. If things are going better than expected, it'll go green. What you might be able to see is, this covers about 3 years, from the beginning of 2011 to end of 2013. And it's showing that in Cambodia we are still seeing a quite impressive decline in numbers of cases reported. This system is capturing data both from the health information system, which is this blue line, as well as from the village malaria workers, the red line below. And it's very noticeable that actually these village malaria workers really do pick up a very large proportion of cases within the country, and are a very valuable part of the whole system. But we come back again to the private sector. For elimination, it's not just finding some of the cases. It's really trying to find all of the cases. And that's been a real issue in countries where many of the cases go to the private sector. All sorts of systems have been tried by many organizations to actually try and get better reporting from the private sector. It's always a challenge. The incentives for reporting are not very interesting to busy private providers. We're exploring how we can use SMS reporting in parts of Cambodia and seeing if that can be used for improving referrals and also getting information into this National Malaria Information System so that we really do have a real understanding of the burden of malaria there. And that's just showing some of the reporting of malaria cases. Here, actually, it's by the village malaria workers who are learning to use this system, and these they're provided with these solar chargers, which I think they find quite useful. So that's one of the areas that we've been looking at. Another area is, again, trying to find out what's working, what's not working. We do a lot of surveys. Quite a few people in this room have been very much involved in large-scale surveys that we've undertaken in Cambodia, Thailand, and Myanmar more recently. But in addition to surveys on a nationwide scale, which are looking at both prevalence and also coverage of interventions, we're also looking at smaller scales, trying to look over a longer term in greater detail at what's really happening at a very small geographical level to try and get a better handle on some of the drivers of malaria in relation to what we know about the interventions that are happening at the time. Sometimes with surveys, we don't maybe take enough time to actually correlate the results of the surveys to what really happened in terms of timing of interventions and so on. So we thought it might be useful to look at this on a much smaller but longer term scale. And we've got this project which is working in 4 countries, 3 and one to start, which we call Beyond Gaki. Many of you will know Gaki as being the area in Nigeria where there was a project in the 60s and 70s, which was, or 70s I think, which was looking to find out if it was possible to actually interrupt transmission by throwing everything you had in terms of vector control and treatment at a particular area. And it was a district in northern Nigeria called Gaki, and we're just about to start a site in the same district, I'm hoping, so just partly because it would be nice to see what's happening in that same place, and the people in Jigawa seem up for that. But this project also happens in Uganda, Ethiopia, and Cambodia. So we're using the same sort of approach in the different countries. And in Cambodia, it really is looking at the low transmission end of the scale. We want to do it in several different settings. But in Cambodia, we're really trying to assess the conditions that go towards pre-elimination and elimination goals and use it to develop recommendations on response systems. This is actually our Beyond Gaki project in Ethiopia. Ethiopia is an interesting country for us in terms of thinking about some of the pre-elimination strategies. There are areas there where transmission now is becoming much lower. I know Tarakan's been having some difficulties finding mosquitoes to process there. And so we're very interested to look at how we can take the information between Cambodia and Ethiopia. So in the Southeast Asia region, we do find that the patterns of malaria transmission are very dynamic. The changes in that region are very, very rapid, the ecological and socioeconomic changes. The point was made this morning about the successes in Southeast Asia are probably more due to deforestation than malaria control, and I think I have to agree with that to a large extent. At the same time, there are concerns that the patterns are changing, and that even when the forest is gone, there is still some risk. It's this lower level transmission that we really don't understand. We've never bothered about it all that much in the past because we've been so focused on the bulk of high transmission. But now we have to be much more targeted. And there is a lot that we really don't understand in Southeast Asia. I think it's been a bit of an eye-opener to us, the recent information that you know, the more blood you look at, the higher this underlying asymptomatic parasitemia is in areas where people are unlikely to have all that much immunity. So there's a lot that we really don't understand. And so we're hoping to try and understand better in this setting and then see how that applies in our Africa programs. One of the things that's a very important feature in the changing environment in Asia is the extent and the nature of the mobility of the populations there. The patterns of migrant work and movement of populations are very complex, and a lot of work's been done to develop an understanding of all the different migrant groups, what they contribute to the problems of trying to move towards elimination. And obviously, it's an area which is quite challenging to get information on because it changes over time, and I think it's become a little bit less predictable than it used to be. I do think, though, that although at the moment we are focusing very much on migrants as being perhaps a major concern in terms of moving artemisinin-resistant parasites from one part of the world to another, which is a genuine fear, and the amount of intercontinental movement of workers is a big concern in that respect. But I have a feeling that in Southeast Asia, what we're likely to find, if progress continues, is it may not be the migrants that are the last holders of the malaria parasites in the region. It's more likely to be some of the really isolated ethnic minority groups who are very disconnected from the health services and also somewhat politically isolated. So we're doing quite a bit of work testing a number of interventions that can be used as part of elimination strategies. In the old eradication days, there were very clear operating procedures for active case detection, passive case detection, etc. Some of these need revisiting now, partly because the tools we have are different. The approach is quite different. One of the ones that we're looking at the moment is strategies for screening for asymptomatic malaria in houses where a case has been reported. So trying to find out approaches that are feasible, don't need excessive amounts of management from central level, but are clear enough for people to be able to take local action. And there's a lot of things we don't know. We just, for instance, when you want to respond to a cluster of cases, issues about how far do you go around the index case? Do you do a kilometre around because maybe the mosquitoes won't fly beyond that? Or do you have to take into account the shape of the villages, the movement patterns, etc.? There's a lot we don't know, but we need to find ways that we can come up with something that is actually something that can be applied. Another project that we're looking at is working closely at cross-border points and looking at how to develop algorithms to actually pick up the people who are most likely to actually be harboring parasites. So the work on responding to resistance is actually, in some ways, quite useful in terms of learning from malaria elimination, because it sets a deadline. We really don't have too much time to respond, particularly to artemisinin resistance in this area. If we can't eliminate from the area affected fairly soon, then the risk of spread elsewhere is a major concern. Obviously, we don't quite know, is it going to be a case of spread, or is it going to be emerging spontaneously in different areas? There is more information coming up on this now, which is great. Now that there is a marker, we can actually understand that a bit better. But both elimination and resistance response do raise big questions on resource allocation. Certainly when we started the work in Cambodia, it was quite interesting to be putting together big proposals for Global Fund to work on resistance in Cambodia when the burden of malaria was actually going down, and yet some areas in Africa with a far greater burden were struggling to get resources. So trying to rationalize those decisions and make them fair is quite challenging. And at national level as well, I think it's quite difficult. Thailand, I think, for example, has very much integrated its malaria program into its general health services, and its ability to have the levels of responsiveness that it used to have are probably waning as a result. But you know, malaria is not a disease they see very much, so it's very hard for them to put in the resources. There's certain beneficial side effects of working on resistance and on elimination. Both need better surveillance, both need to have more effective private sector strategies, and both need to work with mobile populations. Both of them need a certain level of obsessiveness, I think, if you're really going to make progress, because the information that you're working with has to be very accurate and it has to be timely. So I think this has been very much a focus of the work that we're doing. I think some of the things we've learned from doing this is that you have to somehow find reasonable ways of balancing the ideal with the real. We need to really be doing a very intensive, high impact approach, but at the same time it has to be grounded and feasible. So the practicalities of it are quite challenging. I think trying to avoid too much reliance on externally driven programs is an important lesson. There's a lot of capacity in the countries, and for the countries themselves to be able to lead that is critical for the future, I think. It's not going to be possible to just come in and try and take over the way perhaps it could have been done in the past. And then also, I think, just looking at how to have combined efforts, strong partnerships, making sure that we're all going in the same direction, going back a bit to Des's point on alignment. So looking ahead, again, I think it's a lot for us. Our sort of priorities in this area are really continuing to improve implementation based on the results we get from targeted operational research, very much focusing and emphasizing enhanced surveillance and the linked response, and then really looking at a bit more closely at the best use of some of the technical developments that are available, both diagnostics and MHealth for communications and reporting. We'd like to focus a bit more on insecticide resistance management as the other big threat to long-term elimination, and also explore options to eliminate other neglected tropical diseases in coordination with malaria elimination. Thank you.
Thank you very much, Sylvia. It was a great presentation to give an overview of MC's approach to supporting malaria elimination. A bit aware we are a little bit behind of schedule, so I would like to give the opportunity now to the panel members to respond and contribute to the discussion. So, Simon, this is your turn.
So thank you very much for the opportunity, and thank you, Sylvia, for a great presentation. I think you really did identify a number of learnings, and I think particularly look forward to the future in terms of what we can expect. But I believe it's also useful to look into the past And if you look at humanity's scorecard on elimination, it's somewhat mixed. We've eradicated 2, rinderpest and smallpox, on our way to guinea worm and polio. But in fact, there are 4 failed elimination programs from history. That's yellow fever, hookworm, malaria, and yaws. And many of these programs in the past were very high-profile programs. In fact, the hookworm and yellow fever were initiated by the Bill Gates of the day, Roca-Feltrer, in the early part of the 20th century, where he invested a large amount of his effort into trying to eliminate hookworm and yellow fever. And I think the important part of these programs, they did have a lot of emphasis on international programs and international international staff and international programs. And as Sylvia rightly mentioned, it's important to have a local ownership, that these programs actually support and leverage the health systems. They do not distract from them. And I think that's an important thing we need to consider. As Sylvia rightly emphasized, there's a strong need for good surveillance system, case detections, and that obviously is important in terms of quality data, but also ownership of that data as well. And there's a strong need for good political commitment and long-term funding, because these programs are not straightforward. We need to be able to fund them over a long period of time, and we're finding that for guinea worm and for polio, that in fact it's the last mile which is the most difficult part, and it's increasingly hard to convince funders to continue funding a program where in theory you've nearly eliminated it. So I think we need to be conscious of that. And of course, finally, we need to ensure that these programs and these efforts do not distract from the core business of disease control. We recognize that malaria is endemic in many parts of the of the world, and we need to concentrate efforts there. And obviously, we don't need to distract from the core business of healthcare delivery. And I think this is the important role of the Malaria Consortium, with its emphasis on strengthening health systems, on having an integrated approach to diagnosis and surveillance, to having a strong partnership with local countries and the ministries of health, and that moving forward, the consortium and its partners will be able to make efforts to help eliminate malaria, but also other diseases as well. So thank you for all your efforts and your continual efforts.
Thank you. Dysoley, would you like to now give your thoughts on Sylvia's presentations?
So thank you, Sarah. So dear Dr. Sylvia Meek and dear fellow panelists and distinguished guests, so first of all, I would like to thank the Malaria Consortium who invited me to join the university event. So it is my first time in London, so I support not to be here, but as my director is busy, so I'm come on behalf of him. So I know some people in this room, but I'm very pleased to meeting you all today. So I consider it is a great pleasure, as well as to be a privilege to be asked to share a sort of my short issue on the keynote address, so eloquently and brilliantly delivered by Dr. Sylvia Meek. So in order to tackle artemisinin resistance, so in the Southeast Asia, so I would like to share some experience. So as you may all be aware that we, the people of Cambodia, so have a first-hand experience of artemisinin resistance. So I think resistance to anti-malaria drugs so have been a long distance problem in the greater Mekong sub-region. So as I know, in the late 1970s, so in the Cambodia-Thailand borders, there is a global epicenter of emerging drug resistance, so in the anti-malaria drug. So it is in this area that the parasite resistance to chloroquine so first developed, and then followed by the resistance to sulfadoxine pyrimethamine, and then to mefloquine. But I think that the first case of confirmed artemisinin resistance were found in Cambodia-Thai borders in late 2006. So I think even those the artemisinin-resistant containment projects was implemented so during the year 2009 to 2011. So under WHO leadership and Bill Gates Melinda Foundation funding, but the resistant parasites did not yet to be eliminated. But by the end of 2013, so resistant to DHA piperacin, so introduced only in 2009 in the countries that already now demonstrated in 5 out of 20 endemic province, so in Cambodia. But not yet still, I think resistant to the resistant also introduced, demonstrated against the Malaron. So it's a non-ACT that have been introduced as a first-line treatment in the Pailen province. Pailen province, since barely a year back. And then now, so now we have been taken firm decision to undertake the drug rotation from DHA piperacin to artesunate plasmapocin, guided by the prevalence of PF-MDR1 copy number in these 5 artemisinin-resistant province. I think we also have a universal parasitological diagnosis, to better target appropriate for treatment anti-malaria drug. And then we also plan to ensure that every malaria treatment, so in every health at the village level or government facility or in the private provider and so on, so it's directly observed. I think we also are scaling up our surveillance system, so in order not to miss every malaria treatment at a single malaria treatment at our marks, forward to malaria pre-elimination and elimination. So I think what we have learned from the artemisinin resistant, so is manifestation of slow parasite clearance, and then the reduce of parasite killing is very low. And then we also learned that it can be identified as an ex vivo test, measuring the rinse state susceptibility. And then we also have experience in associated with conserve with ACT, efficacy except the following partner drug is used. But what we need to learn more is molecular basics, so whatever is monogenetic or multigenetic. And then what we have to learn more is the split or multi-independence emergence. And then what also we want to learn more is how to ensure that sustainable high coverage of mobile population with the key malaria intervention is successful. So I think that is a thing that we learn from the artemisinin resistant. Yes, thank you.
Thank you very much. We give the opportunity now to our third panel member, Chris Drakeley, to respond to the comments. Thank you.
Thank you. And I'd like to say thank you to Sylvia and the rest of the Malaria Consortium for asking me to come along. I've been kind of regularly involved with the Malaria Consortium since about 2007. And as Arantxa said in my blurb, my prime reason is to try and measure malaria transmission, and the attraction from working with the consortium is that they're working in very operational settings where such measures of transmission are really pertinent. One needs to know the exact measurements at that time in that real-life setting rather than contrived settings which may be created by, say, randomized control trials or other settings. So here we have an operational setting in which we want to be able to determine transmission levels so that we can work out the effective interventions that we're employing within those specific operational settings. And so I have a few comments and observations around how we measure transmission, and in particular in relation to kind of malaria elimination. As Sylvia pointed out, it's becoming increasingly clear that our standard metrics, our rapid diagnostic tests and microscopy, are not particularly sensitive in establishing all the parasite infections within a population. And we estimate that across the board there are 50% more infections when we use a molecular assay. And that proportion is very much higher at low transmission intensities. And so aside from challenging our dogma that in these low transmission settings all infections we would expect to be symptomatic because these individuals should not have immunity, that's a kind of different argument. What it means is we have a lot more infections within that population. There is some conjecture as to how important they are to the onward maintenance of transmission within that community. And it may be that they are less important in areas of Southeast Asia where competent vectors have kind of fragmented ecological niches. But they're probably increasingly important in Africa where, broadly speaking, vectors are pretty much omnipresent and able to transmit all the time, and they are good vectors. So the question is, how do we move forward? I think there's an increasing realization that we need more sensitive tools to work with, and that these tools might be combinations of tools in the sense that they detect both infection at that time, but also recent exposure to infection, so that they're much more tractable in their immediate kind of interpretation. One can say, okay, that person might not be infected now, but they were recently exposed. So you have a dual measurement. And the way they might be used is when one's thinking of a control intervention in a very low transmission setting, we know that the signal or the number of cases that we would detect with our normal measures are very, very low. So we need to employ these highly sensitive metrics. And so there again creates a dichotomy in the sense that we still need the simple tools like the RDT for the use that would enable a treatment of a positive case, but also perhaps a more complex and detailed molecular or serological assay that could be done by Dr. Dysoley in his lab to look for more exposure and changes in transmission over larger scales to help them redefine and reallocate their control program allocation. It should help realise and rationalise the use of funds. And I suppose the last point I'd like to make, and I don't know the answer to it, is how do you measure zero? We're talking about elimination, and elimination is, means the absence of parasites. And it's not immediately straightforward. The WHO have changed their definition about 10 times in the last 10 years, and I'm sure they will continue to do so, until we continue to provide them with better information. But it's not quite simply that the absence of cases means the absence of malaria. The UK is a malaria-free country, yet we have a few thousand cases every year. So we really need to work on how we measure malaria at these low transmission intensities, how we incorporate that data into the surveillance systems that the consortium are developing along with the control programs like Dr. Dysoley's, and then how we provide that information to say malaria has gone. So, thank you.
Thank you. We have some time to open up for the audience to ask any questions. You can see one. Werner? Is there a microphone?
I can speak loudly. Yeah, thanks for the presentation, these great comments. I'm just curious, because most of what we've appear to be talking about is elimination of falciparum, and yet in this particular area of Cambodia and Southeast Asia, vivax is obviously another important parasite, and yet some of the challenges with vivax elimination are in some ways even greater than falciparum. But it gets into the issue of community engagement, how this is communicated. How do you actually, in an effort with the village malaria workers, with communities, these extra push to eliminate falciparum, when vivax may still be there, are there any particular issues or challenges which come out of that? In other words, will we lose communities if we say we've eliminated malaria, but there's still vivax? Sylvia,
do you want to answer?
I can start, and then I think others might, Dysoley might have something to add to this. It's a problem. Vivax is in some ways a lot more difficult to eliminate because it doesn't always need an additional mosquito bite to lead to another episode. And you're right, it can send confusing messages to people. I guess the strategy in the Greater Mekong sub-region has focused quite a lot in the elimination of resistance part of it on falciparum as the first priority. But I think more and more people are starting to broaden that out to have a malaria elimination strategy, which means finding ways of improving those elements of the malaria program that focus particularly on vivax, and that's quite difficult in terms of treatment regimens for radical cure of vivax, which are very difficult to implement, but not impossible. It's there are concerns in that particular area because of potential toxic effects of the drugs, and that makes it more challenging. But obviously, quite a few of the strategies are going to affect both species, and there are a few other species hanging around as well, but luckily less important at the moment. So I think now more and more people are starting more explicitly to address the needs for vivax elimination. But if Dysoley can correct me, but I think the time frame that has been set in Cambodia is longer for vivax than for falciparum.
Yes, so I would like just to add some answer to Dr. Sylvia Meek. So if you look at our elimination strategies, we have clearly stated, so by 2015 we tried to eliminate the Plasmodium falciparum, and then by year 2020, and then we tried to eliminate Plasmodium vivax. But at the same time, now we try to eliminate Plasmodium falciparum as is very decreased, in the country, and then we try to add the primakin, to clear the gametocyte in the liver. And then we also discuss about how to eliminate Plasmodium vivax as well. But as it concerns of GCPD in Cambodia, so we now try to do some operational research for the primakin safety, in the community.
Thank you. Any other question? Diana?
Again, I have two questions that have come through our Twitter feed. The first is, how do you maintain motivation and skills among village malaria workers when malaria is not seen as a threat anymore, especially now with dengue being more of a problem? And the second is, when we near eradication, how can we identify and mitigate against risks associated with generating immuno-naive human populations?
Okay. On the first question, I don't know, perhaps Dr. Sylvia or...
So thank you. So how to maintain the motivation of malaria workers? I think in Cambodia, so all the country, different from other countries, we can set up, malaria village workers, in the malaria endemic area very easily, and then we have a system, we actually to motivate them. I think first, we have to accreditable them, so we train them, we accreditable them, and then people will assist a lot in the program, to help for malaria, let's say to treat malaria in the village, and then to transfer malaria to, in case of severe malaria, they can transfer to the referral hospital or health center. But the way to motivate them, I think we have very small incentive, to give them. But as we train them, and then we give them, well known, and then they try to continue to work for our program, as well as to eliminate malaria in their village as well. I think.
Yes, just to add a further comment, I think one of the reasons I was asked on the panel because the perspective of neglected tropical diseases, and as you all know, there are a number of NTDs that have been identified for elimination, trachoma, river blindness, and also lymphatic filariasis. And I think they suffer the same concern about motivation, in that once the overt morbidity has gone away, communities are less likely to take drugs on a regular basis, because they say, my hydrocele has sort of, not hydrocele, that's a bad example, but my morbidity has declined, therefore I don't need to take treatment anymore. So the question is, how do you sustain that coverage? And I think this is the key about good community education, working very closely, very specifically with communities to ensure that they understand the benefits of the intervention and the need to maintain them. And I think that's true whether it's NTDs or malaria, whether it's Vivax or falciparum. So,
I think that is going to be key as well in terms of examining receptivity to infection in this, what we would eventually hope to create is this immuno-naive population. Clearly, having systems set up and an appreciation and awareness that epidemics may occur and that the form that they may take is going to be part of that community awareness. And so heightened education around the time of elimination is something that's going to have to be developed.
Yeah. Just on the first question as well, the issue of losing skills when, if you only see one malaria case every 3 months, are you actually going to remember how to treat it? Is a big one. And I think also, who are the village members going to remember who their village malaria worker is if they don't need to go to that person very often? And so I think one of the things that countries in the region are actively exploring, again, it goes back to the earlier session, is what is a viable mix of roles for a particular community volunteer. So the questioner was mentioning dengue, which is an absolutely massive problem in that area, and actually very neglected, surprisingly, because it's so common, and people do remarkably little about it. And are there opportunities for the same village malaria workers to take on some role for other diseases? And I think, I know in Cambodia there's been a lot of interest in actually exploring their role in treating pneumonia and diarrhea as well as malaria. But again, it gets us back into the same issues that we discussed before in terms of overloading the volunteers or issues of incentivization. But something that there are possible practical ways of dealing with.
Yeah, perhaps just to add that, yes, in Cambodia there is this example of these expanded village malaria workers where they not only, as malaria goes down, they can also address additional diseases. But also linking to the second point, I think they will potentially have a key role on providing BCC messages, because there are now strategies to update BCC and IEC materials to keep on providing awareness to communities on what is likely to happen in this particular context now that it has changed. This is something that will require quite a lot of attention as well. Maybe one last question, and I think we will close. Any other question? Diana?
Sorry, the Twitter feed is thriving, but I'll stick to just one. This is a direct question to Professor Brooker. How do we sustain coverage? We need strong community communication and engagement. I don't know if it's answering its own question, but...
Well, that's a very good start, I think. It's a very good question, and the answer will vary according to context. And this is why the work of the Malaria Consortium, working in partnership with national control programs, is so key. By understanding what's appropriate for a given community is the way to ensure that we can sustain high coverage to be able to achieve the goals of control and elimination programs.
Thank you. I would like to just now close this session and say thank you to all the panel members for being here today, and in particular to Sylvia for a great presentation. And I think Sylvia has maybe some final remarks to say.
Nothing very much at this stage. Just to say a big thanks to everyone for coming here today. It's been wonderful to see the turnout that we've had. Thanks for those people that are out there on Twitter for doing their whatever it is they do to actually communicate with us. I think it's a great way of engaging with more people, and I know a number of our staff in our country offices have been following what's going on. But I enjoyed very much the interventions from all the panelists. I think it's very thought-provoking to see what your responses are, and just on that I'd like to say thanks a lot, and we'll keep collaborating. Thank you.